In this video, we'll study about ovarian tumors. So, this is Dr. Rahul Isam here. I'll guide you through the whole topic. But first, we'll start with the summary of ovarian tumors, right? So, the ovarian tumor is usually considered as most deadly gynecological neoplasms. So, based on the type of the tissue, because we have different types of tissue in the ovary, so based on the type, it's classified as benign and malignant. And usually the normal ovary is almond shaped, and the size of normal ovary is around 3 into 3.5 into 2.5 centimeters, right? So next we'll study about the risk factors of ovarian tumors. So the risk factors include age, genetic predisposition, the mutations of BRCA1 and BRCA2 genes, they cause ovarian tumors. And also you have hormonal factors such as, the most important thing is, we know that every woman of all reproductive age, they ovulate every month. So the greater the ovulation, so the greater the increase of scars in ovary. So that causes ovarian tumor. And also infertility, early menarche and late menopause, and also endometriosis. And also asbestos exposure can also cause ovarian tumors. So these are the risk factors or the causes of ovarian tumors, right? And most importantly, you have a family history. So family history of breast cancer, ovarian cancer and endometrial cancer can also cause ovarian tumors, right? And then we'll study about the clinical features of ovarian tumors. However, the ovarian tumor is usually considered as asymptomatic silent killer, but 90% of the patients, they do exhibit symptoms before the diagnosis, right? So the symptoms include the subacute symptoms, so usually the patient manifests with subacute symptoms. So these symptoms occur in early stage disease. So the subacute symptoms include adnexal masses. So these adnexal masses can be symptomatic, and this is usually found on routine pelvic examination or imaging. And comes the pelvic and abdominal symptoms. So pelvic and abdominal symptoms include the changes in urination or abdominal distension, bloating, early satiety, and non-specific pelvic pains. And you have this abnormal uterine bleeding. So this abnormal bleeding, such as postmenopausal bleeding, and it could be also rectal bleeding. And also we have the paraneoplastic syndrome. Right. So next we'll study about the acute presentation and symptoms of metastatic disease. So when the patient presents with the symptoms of metastatic disease, that is actually an indication for evaluation and treatment, right? So what are the symptoms? So usually it starts with the extrapelvic symptoms. So the extrapelvic symptoms include ascites, malignant pleural effusion, and bowel obstruction. So these are the extrapelvic symptoms. And comes the hematological complications. So hematological complications include a venous thromboembolism, and also intrapelvic symptoms such as ovarian torsion. And finally, you have the symptoms of metastatic dissemination. So the symptoms of metastatic dissemination include so let's consider if the tumor has metastasis into the liver, the patient exhibits symptoms such as nausea, jaundice, and ascites. And if it metastasis into the brain, you have headaches, seizures, and focal monitor deficits. And if it metastases into the omentum, you have a omental caking. So what do you mean by omental caking? So it is the disease infiltration of omental fat. So that in turn causes abdominal pain, right? And you also have the metastasis into the lymph nodes. So usually it is supraclavicular or inguinal lymphadenopathy. So guys, next we'll study about the classification of ovarian tumors. So this is such a long topic, so I'm not going deep into the topic. We'll just study about the basics of classification of ovarian tumors, right? So the first classification is epithelial ovarian tumors. So speaking about the epithelial ovarian tumors, so usually they arise from, as we discussed already, the types depends on the tissue they arise from, right? So the epithelial ovarian tumors, they arise from the ovarian surface epithelium. So they are most commonly benign. They are mostly benign, and these comprises around 70% of all ovarian cancers, right? And usual age of presentation is from 60 to 70 years. And also you have the subtypes of epithelial ovarian tumors. So that subtypes include cystadenoma. And in cystadenoma you have serous cystadenoma and mucinous cystadenoma. So both are benign. And comes the Brenner tumor. So this is a classical examination of so this is the classical picture of Brenner tumor. So usually the Brenner tumor, the age of presentation is around 40 to 60 years, and this is also associated with pseudomake syndrome. And finally you have endometrioid carcinoma. So now we are done with the classification of epithelial cell tumors. So now the next classification of ovarian tumor is germ cell tumor. So coming to the germ cell tumor, they arise from the primordial germ cells for example oocytes, right? And these can be benign and also malignant, so they can be benign or malignant. And also you have three subtypes in germ cell tumor. You have yolk sac tumor, and you have the malignant or benign teratoma cyst of ovaries, and you have dysgerminoma. So now we'll just have a brief study about the subtypes. So as I told you, the germ cell tumors, they have three subtypes. Number one is teratomas, as I told you. The second one is dysgerminoma, and finally you have yolk sac tumors, right? So these are the classical pictures of all these subtypes tumors. So this one is the exact presentation of malignant teratoma. So the teratoma can be benign or malignant, right? So you have this dermoid cyst of ovary. So this is the most common teratoma you can find, and usually 10 to 15% they are bilateral. So this is an example of a teratoma cyst. So that this is actually a dermoid cyst. And coming to dysgerminoma, the most important classical feature is seminoma type cells. So the cells are arranged back to back and they have clear cytoplasm and dark stained nuclei. So this is a classical picture of seminoma type cells of dysgerminoma. And finally coming to the yolk sac tumor, the classical feature of yolk sac tumor is Schiller dual bodies. So this is a classical picture of Schiller dual bodies. So in these, the vessels with tumor cells around in a cystic space. So this is the histological finding in yolk sac tumor, right? So now we are done with epithelial tumors and germ cell tumors. Now finally we will study about the last classification of ovarian tumor, which is sex cord tumors. So in sex cord tumors, they usually arise from sex cord cells such as Sertoli or granulosa cells, or it could be stroma cells, could be stromal cells, example fibroblasts or primitive gonadal stroma. So this can be benign or malignant. Now we'll have a brief study about the subtypes of sex cord tumors. So you have two subtypes in sex cord tumors. Number one is granulosa cell tumor, and number two is Sertoli Leydig tumors. Also called as arhenoblastomas. So in granulosa cell tumors, the most important characteristic feature is you can find Karl Exner bodies in histological finding. So in this you have contralateral, ovarian, secondaries prior to systemic secondaries. And in sertolio-Leydig tumors, you have the patient presents with the hirsutism, the male patent baldness, and you have excessive hair growth, which is reversible. And the patient also exhibit the symptoms of hyperandrogenism, such as hoarseness, breast atrophy, and the patient also have clitoromegaly. Right. So these are the subtypes. So coming to the summary of the classification and subtypes, you have epithelial tumors, and you have germ cell tumors, and finally you have sex cord tumors. So in epithelial you have subtypes such as cystadenoma, which is serous and mucinous, and you have Brenner's tumor, and then you have endometrial tumor. In germ cell tumor you have teratomas, there is germinoma, and you have yolk sac tumor. And coming to sex cord tumor, you have granulosa cell tumors, which is the most common, and then you have Sertoli-Leydig tumors or henoblastomas. Right? So now we'll study about the staging. Staging of ovarian tumors include stage 1, where only ovary is involved. You have only ovarian involvement. In your stage 1 you have stage 1A, B and C, and then you have stage 2. In stage 2 you have ovarian as well as pelvis involvement, and you have stage 2A and stage 2B, and you have stage 3, where you also have abdominal and visceral involvement, and in this you have stage 3A, stage 3B and stage 3C, and finally you have stage 4, where you have malignant pleural effusion. So here you have stage 4A as well as stage 4B. And now we'll study about the diagnostics. So in diagnostic, you should have the ultrasound features of malignancy, and you do transvaginal ultrasound. As I told you, usually it is bilateral, and you have surface irregularities, and ascites is also present, and you have cystic and solid areas together. Alright, and then you do CT or MRI for further evaluation. Right, and finally we study about the treatment. Treatment of ovarian tumors include the surgical resection, you have to do laparotomy to remove the tumor, optimal debulking, usually less than 1.5 centimeter is the maximum amount that can be left, right? And also you can give chemotherapy, usually platinum based chemotherapy is given. And usually in ovarian cancers or ovarian tumors, radiotherapy is not suggested because normal ovary is radiosensitive, and all the ovarian tumors, they are radio resistant, right? Exceptional case, you have dysgerminoma. Dysgerminoma is the only type of ovarian tumor where it's radiosensitive. Other tumors where it's very radiosensitive, and other tumors are radio resistant. I hope you guys are clear about ovarian tumors. I'll give you a heads up on the next video. Thank you for watching.